problem is, and then finally to hear from everybody about how stewardship and careful use of antimicrobials, how we do that. Antimicrobial resistance, we know it's genetic. There's random mutation. There are some mutagenic agents that result in changes in the bacteria, or fungi or parasites, and to an extent viruses as well. There's a lot of horizontal transfer of genes between species, but there are also these rather irksome mobile genetic elements, plasmids, which can jump across easily, little pieces of encoding DNA that will go between species and convey resistance that way. Of course, we know all about evolution, but then there's evolution by natural selection, and the natural selection pressure here we're talking about is the antimicrobial agents, and then you select for resistant bacteria which survive and replicate. This is a pictorial to show all of the ways we're talking. The focus really is on bacteria, but I must acknowledge all the other organisms that do exist. I'm a microbiologist, but there are clearly other organisms this applies to, but it's a bacterial cell. And it shows all the ways that the bacteria are clever in evading antimicrobial attack, whether they change their target site or they push the antimicrobial out, they crunch it up through enzymes, or they stop it even getting into the cell in the first place. I think we're all familiar with that. This is a depressing image of how few antibiotics we have in the pipeline. So we have above the line, we've got circles of the same color that correspond to an antimicrobial agent. Below the line is the date of discovery. Above the line is the same corresponding color circle of when antimicrobial resistance to that agent was first identified. And we can see how quickly that happens. And then the yellow circle highlights 30 years since a truly new class of antimicrobial was developed, of antibacterial was developed. But of course, when we develop new agents, we have to be careful with them. So the pipeline's an issue, but what we use of our own agents currently, existing agents, is just as, if not more important. So where's the issue now? So I've occasionally now been saying, well, MRSA is passé. If we look at our bloodstream infections, this slide is 2018, but this data is replicated today. And this slide demonstrates that the burden of resistant organisms lies in the gram-negative. So the pie chart on the left is of all bloodstream infections. And then we can see about 50% of them are caused by E. coli and a further 20% by other gram-negatives. So these are our gut, what we call Enterobacterales, all our gram-negative species. The right-hand pie chart shows which of those bloodstream infections are resistant to at least two of our major classes of antibiotics that we use routinely in our practice. And we can see there how much greater a proportion our gram-negatives are a part of in resistant infections. The little table below reminds us of some of the names of these resistant organisms. I know our audience is wide. Many people will be familiar with these names, but there are ESBLs, which have resistance to some of our routine antibiotics, cephalosporins, penicillins, and then we've got our much more frightening and worrying carbapenem-resistant organisms, the carbapenems being our broadest spectrum antibiotics in routine use. Gram-negatives lead the show. E. coli is the main cause of bacteremia, although in fact we'll learn later it's Klebsiella that's probably the worst offender now in terms of our very highly resistant organisms. But we're talking about resistance to our workhorse antibiotics. So the cephalosporins, cefuroxime, ceftriaxone, piperacillin, tazobactam, gentamicin, and amikacin. This is an example, it is a real live example of the sort of organism that we fortunately infrequently see coming through our laboratory. Infrequently, but we see it and we're seeing more of it. So we can see this is a lab report with a Klebsiella pneumoniae. On the left-hand column, we've got all of the various standard agents we would choose to use, and then the bright red R's stand for resistance. And we can see this organism that we have cultured in the laboratory is resistant to everything. The comment, will I create a superbug? Actually, that came from a patient. I talked about this in last year's Grand Round, who very altruistically and very sadly was talking about his concerns about brewing a super bug in him that he might convey to other people. So the public are thinking about it, patients are thinking about it, and then we're all thinking about it too. Rehearsing the issue of evolution by natural selection, we end up in the situation more antibiotic use leads to more resistant bacteria. If they are fit species, so they survive well and they persist, then unless we have good infection control, all of those resistant bacteria spread around the immediate environment of the patient. They're a problem for patients themselves at individual level, but they will then spread across a ward, throughout a hospital, nationally and internationally. And we do see this, we know this very well. So this is a slide very kindly donated, I think, from Ollie, one of our antimicrobial pharmacists, just showing how nicely, thank you very much, these bacteria spread across countries and globally, thanks to not just our travel that we have, we're an international species now, aren't we? But we also have healthcare travel, and we can see this horribly resistant Klebsiella pneumoniae spread between countries. Why do we get this resistance? Well, our level of antimicrobial use is a huge driver. So use stroke misuse in humans and in agriculture. Agriculture is where about 70%, 75% by kilo of antimicrobial use happens. Poor infection control, so important, as we spoke before, and we'll speak later on. And then we spoke a bit about the jumping genes, the plasmids. That doesn't help if the encoding is on very easily transmissible genes, encoding of resistant phenotypes, how fit they are, and then the travel health tourism we spoke of before. They can come in. So this is a picture that demonstrates all of the factors that are involved in this antimicrobial resistance issue, worldwide issue. And we can see them without me having to talk through each individual one. And we know that this is recognised, as I'll mention briefly later, in the One Health approach that is promoted by the WHO to try and address antimicrobial resistance. But we can see this isn't just one or two arrows, it's multiple arrows. This requires a broad approach. I think it's important to talk about agriculture, where we said that 70-75% of our use of antimicrobials exists. About 100,000 tonnes of antimicrobials sales are issued per year globally. I think that's astonishing. I'm sure you do too. In the UK, the routine use was banned and across the EU in 2006, and that was routine use. So antimicrobials used to be used in those areas in the world just as an indirect growth promoter by reducing frequency of infections. But now that no longer happens, it's no longer allowed for this to happen. But it's still utilised at individual and sometimes in a smaller group level. And we have seen decreases in UK agricultural use. It isn't just livestock, but it's also used in the growing of plants as well. But we've still got some very high use of antimicrobials in agriculture across the world, led by India, USA, China, Brazil, Australia. And we can pick out there, it isn't just the people we like to berate for behaving badly and doing bad things. You know, the USA and Australia are sitting there very nicely as top 5 users in this situation. I hope people can see that at the very top, the heading is Global Change in Human Antimicrobial Consumption by Country and Income. The headline figure is 50 billion daily defined doses per year in 2003. So defined daily doses, DDD, that's our standard unit of measurement for antimicrobial consumption. And it just allows us to compare. It's imperfect, but it's a way of comparing our usage with ourselves and across countries. And what this shows is, so on the top, we've got a graph of how this usage has changed across the years on the y-axis, on the x-axis 2016, 2022. And we can see there's increase in all of the countries of various levels of income. And at the bottom, it reflects again that there is an increase. I think it's interesting to see the high income countries, which is the blue line at the top on the graph, There were dips in those for those countries during COVID. There were fewer conditions being treated other than COVID, fewer surgeries, people didn't present, and then it's bounced back up to a high level. But the next line, the blue dotted line, the lower middle income countries, that's at a high level. Given the relative paucity of healthcare, they're using a lot of antimicrobials, and that is going up. We'll talk a bit more about that. Again, you can see the red in the more in the map. You can see the red in the more orange areas where things are going up. There are areas of no color, we don't have data for them. Not good data. Another issue. You can find lots of pieces of data to tell you how this antimicrobial consumption issue is changing and worsening. It's thought, looking at one study I read, 30 to 50% of antibiotic prescribing is inappropriate, and that could mean anything from it shouldn't have been given in the first place, it was the wrong agent, it was the wrong dose at the wrong time, and so on. And then secondly, a horrifyingly high proportion of our population across the world have received at least one antibiotic in 1 year, in a 1 year period. Antibiotics over the counter, that's a very broad term to say, well, someone has received an antibiotic without any medical oversight. So any medical specialist actually prescribing. And that is, of course, a big concern. We know that this prevalence of such administration or receipt and consumption of antibiotics, it varies a lot between countries across the world, even within a country, urban versus rural areas. We know it's a bigger issue in lower and middle income countries. There may be regulations, thinking about our third point there may be regulation, legislation in place, but enforcement and oversight is lacking. But then lastly, to recognise very clearly that, of course, it's easy to blame people, which we never should. We really should rely on systems. I'll talk a little bit about that later. Blame people for going to buy these antimicrobials. Well, for some people, it's their only point of care. They don't have any infrastructure. They don't have the healthcare services that allow them to do anything else. I don't think it's just because I'm an infection specialist that I find this horrifying. I went onto the internet, and lo and behold, what could I see on sale but an oral carbapenem? So remember, the carbapenems are our broadest spectrum of antibiotics in routine use. I say routine cautiously, they're not to be used up front. They're still our reserve antibiotics, but they're available in our hospitals. And we have horrible horrors, oral carbapenems, tebipenem, thoropenem, and there are papers that demonstrate that oral thoropenem, this oral carbapenem, is rapidly increasing in use in India, including plenty of over-the-counter unsupervised use. And that, coupled with poor sanitation, I mean, it's not just an accident waiting to happen, it's an accident that has already happened, as we've seen from a little bit of our data so far. So addressing the over-the-counter OTC problem, 2023 was the first global joint summit of human and veterinary medicines overseen by the WHO. I think it's amazing it took until 2023 for that summit to take place. Perhaps others might agree. And I think I'm sure they're an ambitious group, but they set their targets initially for their first meeting on reducing over-the-counter sales with the aim to phase them out completely. But of course, as we said before, from the slide where we had all of the various factors that are involved in the AMR issue, the antimicrobial resistance issue, controlling over-the-counter medication, very important. It is only part of the picture. The lack of infrastructure, the lack of healthcare, the lack of laboratory and public health systems is key to a lot of this too. Not surprisingly, we've talked about how we get resistance because of the selective pressure of our broad spectrum agents. And then if we don't have infection control, and what we mean by infection control in a high income country that we're lucky enough to live in here is hand washing in healthcare, being careful with all of our standard precautions, but actually just at the level of basic sewage, not having a toilet, not having any sewage. And there are many studies you can find in the literature that show on the left here, we can find antibiotics everywhere in our environment. Then in the middle, a reminder stating the obvious that soil and water are great reservoirs for organisms to enjoy. And if they're resistant, then they'll enjoy it even more. And under the pressure of the antibiotics there, the carbapenems is the key example, they're going to thrive. Those resistant organisms will thrive, and they'll be busy sharing their plasmids between them. And we've demonstrated a lot of this resistance, not only in these environments, but also in our fish. I don't know why the crab came up on the slide designer, but fish and plenty of organisms in these environments. A very sad example, and actually it is India, and a lot of the data does suggest that in many ways India is an epicenter for the issue of antimicrobial resistance, accepting that it is a worldwide problem and we're all in it together. 60% of people do not have adequate sanitation in India. I'm surprised by that, but in a way, maybe I'm not, and it's the most populous country on our planet. No toilets, no wastewater, and effluent from industrial effluent and sewage is just being funneled into these lakes and streams that people live by and live close to. You can imagine the result of that. The One Health approach that I mentioned before, that is the WHO drive to address the multifactorial issue of AMR, an integrated, unifying approach to achieve optimal and sustainable health outcomes for everybody, everything on the planet, humans and everything. Everything is interlinked and interdependent. These are maps that speak of the necessity to have infrastructure, systems, and the top left-hand map of the world is the summary of the other three on the right and at the bottom. And what they show on the left, the top left corner map, is a summary of the overall antimicrobial resistance governance status of that nation. Some nations are grey, we just don't have enough data to comment. But we can see that good antimicrobial resistance governance comprises, I can't even see at the top, is it policies on the top right? Top right map, antimicrobial policies, bottom left, the tools to implement these, again, through healthcare, guidelines, laboratory systems, and on the right, the monitoring and evaluation. And we can see where the problems lie nationally, can't we? Again, India, Latin America, we've got Mongolia in red, we've got Ukraine. I don't think some of those colours are surprising to many of us. Apologies, I'm sure you can see that the hot zones are the areas where there's trouble. And this then is reflected, not surprisingly, in where we see the burden of the most resistant organisms. And this is a world map showing, none of the data is perfect, but the estimated data for the prevalence of the carbapenem-resistant Klebsiella pneumoniae. Klebsiellas sit in the gut, and just very, very concerning. Again, sadly, India, and that is Nigeria in orange. Someone please help me out with the other orange. It's not Bangladesh. Sorry, I've forgotten what the other orange country is. Anyway, 50 to 60% of those Klebsiellas are carbapenem resistant. What happens? Tragically, people die. So the current estimate is that about 1.2 million people die worldwide directly due to antimicrobial resistance, and about 5 million associated with antimicrobial resistance. Big problem recognised by the WHO, and the trajectory is not a good one, that we might be reaching 50 million in 10 years, 10 million by 2050. What's the picture like in England? Actually, I think this first data point is England data. In 2019, about 7,600 deaths are directly attributable to AMR, and then 35,000 associated with AMR. And that's now approaching, it's 5 years old, isn't it? So this picture isn't looking better. It's costly. is it called animations? Like the animations are a bit irksome. I've just put everything on the slide now. So we know that what this translates to not only is mortality, but also morbidity, longer hospital stay, awful for the patients, terrible for healthcare systems and flow. And the agents that we have to reach for to treat these resistant infections, they have cost associated and toxicity associated. The yellow square in the middle gives us an idea of one trust where they had a horribly multi-drug resistant gram-negative outbreak and the cost that incurred as a result. Clearly also at the bottom, it shouldn't really be at the bottom, the issue of C. diff that's associated with high antimicrobial use. And other factors, but antimicrobials are key. These are graphs from How We Doing for Time. Okay, I think, hope so. This is a very good survey that's undertaken and published about every 2 years, and it shows us that we've got two graphs here of gram-negative organisms, the gut organisms, E. coli on the left and Klebsiella on the right. For each agent, the two graphs we've got on the x-axis, we've got our workhorse antibiotics that some of you will be very familiar with, you've prescribed them before, and then our y-axis, we've got percentage of organisms isolated that are resistant to those key antimicrobial agents. So 2 bars for each agent, for each organism. First bar is 2019, second is 2023, and for almost every agent, we're seeing increases in the last 5 years of the percentage of those organisms that are resistant. Was there anything else I wanted to say about that graph? Apologies, I don't think so. Let's go on to the next one. So that shows the increase. And then this shows the sorts of combination agents that we use for patients through the door, particularly important in sepsis. We'll hear Narine Sivio, our MRED sepsis lead, talking about that briefly later. And the resistance we're seeing in our bacteremia isolates to those key combination agents we use through the door. On the left, E. coli, on the right, Klebsiella. This is a single time point. This is our most recent data for England. And we can see, worryingly, that the carbapenem resistance, I think maybe the focus, you can see that we've got below 10% resistance for almost all those combinations, which is what we want to see. Fortunately, we still have that. So 90% of our bacteremias will be treated by Kermoxiclav and gentamicin through the door. But look at the Klebsiella, the carbapenems, that's getting higher, and Klebsiella is a big problem. This is our local St. George's data, and this is the sort of laboratory data we use to inform our antimicrobial policies. So we have all of our bacteremias there, our gram-negative bacteremias. Let's focus on the top line. E. coli. So this is E. coli bacteremia isolates. And then the columns are again the different agents. And the focus is on the penultimate column, which is Kermoxiclav and gentamicin. It says Organ-Gent. And we can see that about 86% of our isolates are susceptible to that combination. We'd like it to be a bit higher, and it used to be about 10 years ago, it would have sat somewhere around 90%. But we're still secure in using Kermoxiclav and Gent through the door. But that's just to tell you that's what we're using. And as we've written there, who would want to use, going back to that previous slide, yes, it looks lovely when you see carbapenems have such a low resistance profile, don't they? But we know the story. If we use those up front, what's going to happen? We use them and we will lose them. So combinations are key. Lots of antibiotic about, I'm sure you're familiar. Any one ward we could walk up onto right now, and probably about a third of patients will be on antimicrobials. Antimicrobial stewardship, it saves money. Surgical prophylaxis has got to be right. It's a skilled process in terms of timing. It needs to be given within an hour of skin to knife. And 30% of it, we think we don't quite get there in terms of whether we achieve that. Again, looking at some local data. So this is our St. George's, this is courtesy of Ting Yao, of one of our other senior antimicrobial pharmacists, thank you. And this shows on the x-axis, we've got time going from 2017-18 right through up to our most recent quarter, 2024-25. And the y-axis, the DDDs, the defined daily doses that we're using. So we can see this is overall consumption of our key agents, not every single one, our key antibacterial agents. And we can see that the bar chart's going up and down. And at the moment, the news is looking relatively good. At the end, it's looking as though it's going down, but it's still pretty high. And we've seen some dips in associated with the very sad COVID pandemic, where again, probably you just weren't treating as many of the other sorts of surgical infections and other infections people just didn't present with anymore. So I don't think we should be particularly heartened by this. It's good it's not going up in a steep fashion, but it's still high. What's stewardship? What can we do? Just a quick time check. So antimicrobial stewardship, I always struggle with the term stewardship because it just sounds really weedy. It makes me think of people just gently offering cups of tea or cajoling in it, but it is so important, isn't it? And we will hear later from lots of our colleagues that they also thankfully think it's important. We all agree on what we do to address it, and everyone is involved. And the aim is that we get the best clinical outcomes with our judicious use of antimicrobials for individual patients and to preserve the effectiveness of these antibiotics for future patients. I don't know how many people are familiar with what I think is a really excellent approach that WHO took, which is to categorize our various antibacterial agents into three main groups. On the left, we've got the access groups, and those are the narrowest spectrum antibiotics, which are the least likely to promote resistance. And those are the ones we always like to reach for first whenever we safely can do so. Then the middle group, the watch agents, those comprise our workhorse hospital antibiotics in the main. Quick point, in the UK, we've modified these groups. They have been modified for us to push some of these agents, Kermoxiclav, clindamycin, the cephalosporins being key amongst them, from access to watch. So we're more stringent in the UK, partly because we're aware of resistance issues, perhaps even more in a more heightened fashion, but also because those agents are more associated with C. diff. Data's a bit variable, but we believe that to be the case. This middle group, the watch group, are our key focus in our antimicrobial stewardship activities at hospital level in St. George's. Together with the reserve in the last column, we've got the reserve agents, and these are agents that we don't want anyone to prescribe for patients unless it has oversight by infection specialists, so doctors and AMS pharmacists. And then just thinking about what our stewardship categories are. Well, of course, we understand that we could put categories into two main ones. One is we know exactly what the infection is. We know we grow a group A strep, or we grow an E. coli that's sensitive, or we grow an E. coli, but we don't know the susceptibilities. And for that, we need some rapid tests to diagnose exactly what the pathogen is and its resistance profile, and then some targeted agents, and then lots of alternative drugs in the pipeline, which, by the way, we don't really have if we know early on what resistance is there. But then we've got the other group of patients, which is a huge number, who come in with a fever, and we don't really know what's going on because, of course, fever doesn't necessarily mean infection. And if it does, it may not mean infection that needs treating now with the broader spectrum agents. No. It could also be an infection, but it might be viral. And really, this is a category, certainly in primary care, but not exclusively, where the largest percentage of antimicrobials are prescribed. About 75% of antimicrobials are prescribed in primary care. And then to address these groups, well, number one, well, we know it's an infection, it's screaming out infection. There's, an abdomen or urine with, that's cloudy, the patient's got loin pain, but we still need to know what the organism is. And there's a lot of progress in our laboratory diagnostics in high-income countries. So we've got PCRs, we've got rapid susceptibility tests, but that is very much weighted towards the high-income healthcare setting. And then trying to think, well, we know there's an infection, this group 2 I was talking about, they've got a fever. Is it viral? Is it bacterial? Well, we all look at the CRP, the C-reactive protein for the students here, and there are other tests we can do to look to distinguish between viral and bacterial causes of infection, but none of them are perfect. So what we want to do in our day-to-day work is, as a build-up here to other people than me talking, is to make sure in stewardship terms our aim is always to give the right drug. So it's got to reach the target site with minimal toxicity, minimal impact on resistance. The right person, are they allergic? Are there any other risk factors that make us think they might have resistant organisms? Right dose. One of my colleagues will talk about that shortly in a short video. Right route, right time, sepsis, don't delay. Narani will talk about that shortly, and for the right duration. And that results in improved safety and outcome and preserves antibiotics for the future. So I thought it would be nice to, I hope this works, see if it does, to talk about, to allow some of our colleagues to explain what they do day to day to address this problem. So let's start by hearing from Narani.
Hello, my name is Narani Sivayoham. I'm one of the emergency medicine consultants. I'm also the trust lead for sepsis. Antimicrobial resistance is clearly a problem, and it's a growing problem. In the past, we used to deliver antibiotics to everybody in a rapid time frame, but now, to support antimicrobial stewardship, we deliver antibiotics to a focused group of patients, that is, those with infection and hypotension. And that is where the evidence mostly lies, where there is benefit for the patients. In addition, we routinely prescribe 48 hours of intravenous antibiotics. This is so that there isn't a prolonged duration of intravenous antibiotics. We anticipate that when the patient goes to the ward, that there will be daily reviews of the antibiotics they are on to again avoid a prolonged duration of antimicrobials, which in turn would breed antimicrobial resistance.
I don't think we'll go for any chill out. I'm hoping this will go to the next slide. I'm pressing down and I can't get to the next slide. I'm obviously doing. I am. One moment, please. Just trying to get to the next slide. Operator error here.
No. No, I remember.
Okay. Okay. Thank you very much, Narani, and everyone who speaks, actually, because I caught people for a very short 5-minute time, but that was all our time is precious. I'm very grateful for people speaking and allowing me to video them for this. So this, I think, just highlights what Narani was saying. Where we need to, we give antibiotics quickly, but only to those who we think really need it quickly within the hour. We don't delay. And then we have to review those antimicrobials every 24 hours, but certainly by 48 to 72 hours, results will come in. We will be able to establish whether infection really was the diagnosis that was leading the show for that patient, or whether actually there's an alternative diagnosis. And if we, as and when we get those results coming in, we need to decide with that daily review of antimicrobials whether we can stop them, whether we need to change them. We might be able to narrow them. We might have to broaden them according to what our laboratory shows and what we as infection specialists communicate to you. We can also think about IV to oral switches. That will be spoken about a bit later. Or we might just continue them. OPAT is another issue. We won't talk about that in detail. Just to say on the review front, our antimicrobial pharmacists work very hard to get data at trust level and at ward level as to how good we are at reviewing our antimicrobials within 48 hours. And that is something we need to do better on. It's now dipped to about 70% in our trust as a summary figure. summary statistic for how frequently we undertake that 48 to 72 hour review, and we need to work together to do better on that. Next person, next colleague of ours to very kindly speak. Hope this works.
My name's Dagan Lonsdale. I'm a reader and consultant in intensive care medicine and clinical pharmacology. And antibiotics are a core part of what we do in critical care. Around about 2/3 of patients who come into intensive care have a course of antibiotics whilst they're with us, and a high number of patients are in intensive care because they have a significant infection that is life-threatening. And so you, I suspect, might expect me to say that getting the choice of drug correct and the dose of that drug correct is really important to ensuring that our patients have the best chance of recovering from the illnesses that bring them to us. And there's a lot of things that go into the choices that we make in those regard. The first thing, of course, is understanding our local policies and guidance on antimicrobial prescribing, so that we know we're choosing the right drugs to treat the right kind of the kinds of bacteria that we know exist in our communities. And we need close working with our colleagues in microbiology and infection to understand that. And then, of course, it's understanding some of the patient specific factors that might lead to a dose choice. And those factors might be age, they might be someone who has organ problems, so kidney problems, liver problems, or it might be body size, bigger people requiring bigger doses. And one of the great things about St George's is not only do we pride ourselves in high quality care in this area, but also we are focused on research, and we deliver a number of clinical trials in the critical care here that look to understanding what the best dose of antibiotics is to give to patients. So I'm really proud of what we do as a hospital and as an organisation to care for the patients of today and care for the patients of the future.
Thank you, Dagan. I don't know if you're listening in. You're probably busy on the unit. A couple of things to say. Firstly, that, of course, Dagan is a clinical pharmacology specialist, but there is nowhere like the ITU to be extremely careful and fine-tune the dosages we give, the drug choice for sure. We are using broader spectrum agents. Sorry if this slide is a bit of a distraction, but these are the scenarios where we might use broader spectrum agents. Dagan Lonsdale explained it's about 2/3 of their patients are on antimicrobials on their units, not just general ITU, but cardiac, neuro. And that fine-tuning of dosing, it is particularly fine and careful in the ITUs, but it should also be elsewhere. And we have an antimicrobial pharmacy team who are very busy, but they are always happy to help with that sort of fine-tuning and making sure the appropriate monitoring is undertaken and so on. And we have one of our pharmacists talking about that later. Fine, good. I think that we can go on to the next one. One of our surgeons is kindly going to speak.
We recognise that antimicrobial resistance is a big problem in our patients. We've had numerous patients who have developed antibiotic resistance that's caused difficulties with our treatment. One of the ways that we've identified to help with this is focusing on source control, which for us means operating early when possible, or removing plastic implants if that's the source. We also recognise the importance of prophylaxis in theatre, when to not use it if it's not indicated, but to use just one dose when necessary to prevent infections. Within surgery, we're identifying more conditions that actually don't need antibiotics to treat them. For example, diverticulitis, where there is increasing evidence that antibiotics are no better than placebo, and we've therefore developed a protocol at St George's to support our trainees to manage the patients without antibiotics. And anything we can do to minimise the impact of antibiotics on our gut flora, because as surgeons we know that it's those gut flora that can then proceed and lead to other surgical disease that we are treating in the future.
So I can assure you no money exchanged hands in order to ask every one of these people who very kindly agreed to speak, to say the words that they did, but everybody recognises the importance of this. And another one of our GI surgeons is going to make some similar, but perhaps slightly different points here.
Hi, I'm Mayutan Clendron. I'm one of the general and upper GI surgeons here at St George's Hospital. And it's a really important week this week because it's World Antimicrobial Resistance Week. And we as surgeons see a lot of complex patients, especially upper GI patients across the region. And what's really important for us, we work with our microbiology colleagues. We stick to guidelines quite stringently as much as possible. We make sure that we don't go straight onto broad spectrum antibiotics. We make sure that we carry on the period of antibiotics for the shortest time possible, and that we often enough switch to an oral switch, and often that's quicker than one would anticipate in an unwell patient. So we use antibiotics for the shortest duration as safely possible. We find that the longer we use antibiotics, and sometimes we have to use them for a prolonged period of time in our complex patients, we see more and more the development of resistant bacteria.
So we can see some really key points being brought out by Cleo: surgical prophylaxis, source control, and then by Mayutan, thinking about durations, not giving long durations. Just to take a skip back, because I've seen what slide I put in next on the left, not everything needs antibiotics. And Cleo very kindly spoke about one such condition, which we used to throw antibiotics at all the time, and that was diverticulitis, but it's not the only one. And she highlighted source control as well. Before I go on to Ed, guidelines, we'll talk about that again briefly, but Mayutan mentioned using the guidelines, not just wading in with piperacillin and tazobactam when someone's just come through the door. One of our renal physicians. Ed,
So just to introduce myself, I'm Edward Stern. I'm one of the renal consultants at St George's. I look after our dialysis and transplant patients here. And for these patient groups, I guess the issues are that they're particularly vulnerable to infection, partly because many of them have long indwelling plastic lines. Some of our patients with transplants are on long-term immunosuppression, and many of our groups of patients, particularly the dialysis patients, make very regular visits to hospital. So we're thinking about nosocomial infections as well in those patient groups. And I think so because of all these reasons that the patient groups are more vulnerable, all the things we do to try and minimize infection, minimize resistance are really important. And in particular, the things we think about are meticulous hand hygiene. I myself responsible for the training and care of home dialysis patients, many of whom are accessing their own indwelling lines daily and have to be trained to have aseptic technique. But in a more general sense, we're really fixated on meticulous hand hygiene. We're really militant about getting the right samples at the start of any infection. So, for example, in peritoneal dialysis, we will not give anyone any antibiotics without having a sample of their peritoneal dialysis fluid to use. The same goes for blood cultures in hemodialysis patients and, for example, urine in kidney transplant patients. So we're really keen on early samples in suspected infection. And then I suppose the next thing is choosing the right antimicrobial. So not using too broad spectrum agents so that we promote resistance unnecessarily. And then finally, I suppose the thing to talk about is the length of course of treatment. Often in our immunosuppressed patients, we're thinking about quite long courses of antimicrobials, and we're always having to balance that against the risk of resistance that may be higher in an extended course or a course that's longer than necessary. So talking about duration of antimicrobials, it's important for us that we liaise with our microbiology colleagues if we're considering longer courses of antimicrobials in these immunosuppressed patients because of the risk of resistance that comes with that. So I think those, from our point of view, those are the main things that we're thinking about in terms of antimicrobial stewardship.
Right, you almost think there was a script there, wouldn't you? Lots of important things. Take the specimens first. Durations he mentioned. So we try and move away, I think, from using the term course. Course invokes notions of, well, there is a course and it's a copy and paste for everybody. It isn't. It might be in some settings, primary care may be included in that. We always want to keep durations to the minimum that's safely possible. And we know there is more and more data that what we thought was a safe minimum is shorter than it used to be. So we don't have to routinely give 10 days for everybody with a complicated urinary tract infection. We can give 5. We don't have to give 7 or 10 days for every community-acquired pneumonia. We can probably give 5. And you can see these studies, happy to share them with you in due course. Again, referring to the use of the term course, looking at the last square at the bottom, we have moved away both in Europe and in ECDC, the European equivalent of UKHSA, and CDC, USA. We don't say finish the course. The terminology that's used is take antibiotics exactly as prescribed. Alex Trumpeter will now kindly say something.
Antibiotic resistance is a big issue. In orthopedic infection especially, we have several challenges, not least the difficulty in eradicating infection once it establishes in bone or around metal implants. And therefore, the challenge of orthopedic infection in terms of clearing it both surgically and with the appropriate antimicrobials that we often have for a very long course. And then we've had multiple cases over the last couple of years of people with highly resistant organisms, almost to the point of untreatable or no appropriate antimicrobials, including patients who've come back from Ukraine and the war out there. So resistance is something that we really are anxious about because bone infection can be so hard to eradicate. So there are things we do in orthopedics in general. So we're really fastidious about infection. So reducing the risk of getting an infection in the first place, I think, is really important. So the sterility that we take care of during orthopedic surgery is paramount. But when it comes to things like prophylactic antibiotics around implant surgery, we're seeing less and less evidence about the need for long duration prophylaxis. So we've moved really to single shot only for implant related surgery. And then if I'm treating anything where I suspect infection or we have infection, we really have now protocolized and standardized not only the antibiotic regime around surgery, but the way we collect our specimens and the analysis of the specimens so that we can be really guided with highly specific targeted antimicrobials. And I think doing that with a multidisciplinary team working closely with micro, so we don't have any blind prescribing from the orthopedic side. It's all very tailored to the patient and based on historic specimens or active specimens is really key. We use a lot of local antibiotic in our orthopedic surgery that I think reduces the need then for giving unwarranted or blind IV antibiotics in the parentally in the post-operative period. That also helps. The importance of taking specimens and deep samples when we perform surgery where we're suspicious of infection, and I suspect this extends beyond orthopedics, but especially in implant-related surgery of any sort, is to rely on deep surgical samples taken from the surgical field. Wound swabs are often commensal bacteria and contaminated or so on. So deep specimens in orthopedics, we've learned actually we now take multiple specimens with new instruments for each one. So we don't even get cross-contamination. And actually, there is such good evidence now that improves your ability to detect the causative organism. And then really working on those samples to give you your result and not blindly trialing different antibiotics. So we work closely with our microbiology colleagues. Our implant related samples get cultured for extra long periods of time, and we wait and we wait and we wait until we know the organism, and that determines the definitive antibiotic choice. And I don't make that decision. I allow my microbiology expert colleagues to be the ones who guide me, and we work together. And I think that's something else that we've really come to learn, is that the working as a team through this is the key. No one knows everything. So my skills are in taking the samples, and our microbiology colleagues are in the experts in analysing those and advising as to what the best antibiotic usage is in that situation.
Excellent. Thank you very much, Alex. And again, no money exchanged hands there. We work very well with all our surgical teams, such an important specialty for us to collaborate with. And this was just going back to a specimen that in fact was one of the patients, was the Ukrainian patient who we published a small letter about, who had just such a drug-resistant infection. A few key things have been brought out. Samples, please. Even at the level of a urine, ED is so busy, so not getting a urine in ED, I think happens a lot, and we get that. But, you know, everywhere else, just we do our best to get the right samples, pre-antibiotics ideally, if possible. And just to highlight, Alex was talking really from a surgical point of view about infection prevention, but Ed Stern from Renal used the words militant when it came to IPC, dealing with lines and hand washing between patients. We'll hear about that later. Now we're hearing from Mehul, one of our pharmacists, about their role.
My name is Mehul. I'm one of the senior pharmacists. And all pharmacists play an important role in antimicrobial stewardship. We review every single prescription that we get, review the indication to make sure that we know what the antimicrobial is going to be used for. We check it against our local guidelines and any resistance as well. And we help the doctors to pick antibiotics that are correct for the patient. We also help with monitoring antimicrobes as well in the long term for side effects, checking biochemical markers. And we also help with the therapeutic drug monitoring of the high-risk antimicrobials as well to make sure that they're in range. It's extremely important that all prescribers make sure that they put the indication for the antibiotics on the prescription so everyone knows what the antimicrobial is being used for.
Indication. Do we all know why our patient is on an antibiotic? So for all of those 30% of patients on our wards, we all need to understand why they're being given. We've got micro guide to guide us as to what agent to use. The pharmacists at ward level, but of course our antimicrobial pharmacist experts, are able to guide further if there are allergies or any other issues. Please use what is now the OLAS app. It's not intuitive that that's going to give you antimicrobial information, but it was microguide, but it's been bought by OLAS now, and that sits on the intranet. It sits under antimicrobial guidelines, but that's the new app. Oral agents, people have referred to IV to oral switch. Oral antibiotics can be just as good as IVs, and the patients are so grateful for not having IV antibiotics, as are the nurses, because that takes a lot of nursing time. And there's the infection control risk of having cannulae in. And on that note, we're going to go to our nurse consultant, Jane Calloway, who's one who will speak about these issues. So now we have Jane Calloway, who is our nurse consultant in infection prevention and control, who's kind of going to say a few words about the nurse's role in antimicrobial stewardship and infection prevention and control importance.
Many thanks, Marina, and thank you for the introduction. I would like to speak for nurses on our wards who administer antibiotics to our patients. It is absolutely key that nurses administering antibiotics are aware of the rationale and to know of the reactions to look out for example, rashes or new onset diarrheas. For patients with new onset diarrheas, a team review must be carried out to establish if the onset is likely to be an infectious cause, for example, C. diff. And if C. diff is suspected, the patient should be isolated promptly and a stool specimen collected for testing. Nurses can also be extremely good at reminding and encouraging colleagues to perform a regular, timely review and to consider an IV to oral switch, following which the IV cannulas can be removed and improving our patient safety. A wider issue in our hospitals is the risk of these very resistant organisms spreading from patient to patient, so that onward transmission. And what we already know is key initiatives to reduce that risk is the implementation and the following of good IPC practices or standard infection control precautions, of which one of the most important is our hand hygiene, whether it's between patients or following the 5 moments for hand hygiene. And that's really my plea today, that we are aware of our good hand hygiene and championing best practice.
Great. As Jane was speaking there, I was rolling up my sleeves, getting into that mindset of, we can look at all these areas where we've got, no sewage, no toilets, but we've just got to wash our hands. Jane highlighted the issues, or the reality that nurses administer all of the agents that prescribers are prescribing, and they're right there by the patient. They know the issues of cannulae. They also know the issue of the patient reporting that there's diarrhea. That might be C. diff. We need to diagnose it, recognise it early, and isolate them accordingly. So thank you very much, Jane. IV is horrible for the patients. 42 times the carbon footprint IV agents versus oral. We've talked about these resistant organisms, the carbapenem resistant organisms, and we know we have to screen patients when they come through the door to make sure that we know who they are. They've been abroad in healthcare, they've come from other hospitals. We identify them, screen them early, and then we can isolate them accordingly with the most stringent contact precautions. Seeing's believing. Lovely slide. If we could see this, no one would even think about not washing their hands. I think this is our last one, and this is one of our paediatricians kindly speaking as well.
Hello everyone, I'm Bori. I'm one of the pediatric infectious diseases consultants, and I'm leading the pediatric AMS program in St. George's. We are in pediatrics, we are very careful with our antibiotic usage, and the primary goals are to try to use the narrowest possible spectrum antibiotics and to try to shorten the duration as much as we can. Of course, pediatrics is not struggling as much antimicrobial resistance than probably the adult world, but we do know that the impact of early antibiotic usage in the long term, resulting in microbiome changes and eventually leading to a multitude of diseases or conditions, is very, very significant. And what are the conditions that we're talking about? So this can be as simple as a few allergies to asthma, which is a major pediatric problem. So we are not struggling, as I said, as much as with resistant, but we're also very aware that these are the early years in life, and an initially acquired antimicrobial resistance can actually lead to adult problems as well. And we want to keep guard of our adult colleagues not to deal with a lot of resistance when they reach adulthood. So, of course, the other dilemma is that early onset antimicrobial resistance may last a lifetime. And if we are using up all of our antimicrobials early on, what are we going to be left with later on in life?
Thank you very much, Bori. Bori and I work together in antimicrobial stewardship at St. George's. It's nearly finished. So very clear reference to, well, these children growing up now, if we burn our boats with our antimicrobials, we're not going to have any left to treat these people when they run into issues when they're older. So punchline messages: wash our hands, only give antibiotics when you really need to, and give the shortest duration possible. I think that's it. Any questions? Thank you very much again to all the colleagues who kindly spoke, and to Oliver Smith in comms who helped to edit the videos. Has anyone got any questions? Oh yeah, hello Joyce.
Oh, hi. This is a very useful session, and we'll be sure to try and make sure as many people as possible see the recording. We might even need to play it again. But there was something I just wanted to highlight that has been coming out on reports. I only got to know through Matt Londy what it means. And that's the fact that with antibiotics, it's sometimes reported as SR, and then a new terminology that has come in is I. I don't know if you wouldn't mind sharing with everyone so everyone's aware what this means.
I think everyone will have heard that because you come through online. So thank you, Joyce, very important. So I, just getting straight to the target here, I means increased exposure. So for certain organisms and certain agents, when you see I, it means you do not use the standard dose of antibiotic. And those two organisms are not the only ones, but the main ones are Staphylococcus aureus and Pseudomonas. And for those, we're using in Staphylococcus aureus, we're using higher doses of ciprofloxacin if we need to, and double the dose of ceftriaxone for severe infections. And for Pseudomonas, we're using a higher dose of ceftazidime. You can look it up, but it's 2 grams IV 8 hourly with normal renal function. Piperacillin tazobactam, we're using a higher dose, 4 times a day, 4.5 grams rather than 3 times a day. And ciprofloxacin again at the higher dose of 750 milligrams BD if you're giving it orally. The details of that, very important issue. Thank you again, Joyce. We're going to create 2 new short sections in microguide to deal with those 2 organisms, the management of the treatment of Staph aureus and Pseudomonas infection with respect to dosing and how you interpret that I. Does that answer your question, Joyce? I mean, I think it's something that we really need to, we're working on. Of course,
Yes, it does.
assuming there's normal renal function, which I completely accept, Joyce, that's going to be key for you. But it's a renally adjusted dose to the target dose of normal renal function, which is a higher dose for the I. Okay? Thank you. Someone... It should be. Yes, we will. Steve very kindly organises these to be online. We've got a question from someone called A. What can we do to encourage and empower more diagnostic specimens to be taken prior to antibiotics at the front door? Once they're started, it can be more difficult to interpret. It's obviously a very important question. I do think everybody, we need to remind each other to take the right specimens. Clearly, there are scenarios where it's not safe to delay in a lumbar puncture. A patient with Crohn meningitis, one of them, you get a blood culture, but let's not delay giving antibiotics while we undertake what might be a difficult lumbar puncture specimen. In other scenarios, surgery, well, we do report it in a constructive way if we haven't received surgical specimens so that we can try and work out where the missing link was. In other settings, I'm thinking of ED. It is so busy. I think it's very difficult to hang on and get urine specimens at every call. So I'm not able to easily answer your question other than to continue to inform people and say we really do need to try and get this. And a blood culture is probably a fairly easy win when we're already taking full blood counts, CRP, UNE and NFTs. There isn't really a very good reason, I think, that we can't get a blood culture pre-antibiotics. Any other thoughts on that? Whoever, I'm so sorry. It says AS, and I don't know who you are. But if any other thoughts on that, welcome. Anyone else who's got any questions? Anyone here? Thank you very much indeed. Please look at the intranet. Email me or any of our team and communicate with us if you have any questions about antimicrobials, particularly if you're thinking of using broad spectrum agents or thinking of prolonging a duration. Thank you very much.